Hey, good morning, everyone. My topic is Duchenne muscular dystrophy. Um, and here we have a young man in the center going through physical therapy. Uh, he's still quite young. It's a progressive degenerative disease, but you see he's in physiotherapy. He's still able to stand. He's quite active, and he's flanked on either side by two older gentlemen um, in their early to mid-20s. By this time, they're wheelchair bound. So here we go. What is Duchenne muscular dystrophy? Duchenne muscular dystrophy, also known as DMD, is a rare muscle disorder. However, it is the most common muscular dystrophy affecting children. Duchenne muscular dystrophy overwhelmingly affects about 1 in 3,500 to 5,000 boys. Um, that In fact, that's about 10,000 times more than it affects girls. And girls hardly have any symptoms at all. Essentially, there's a lack of muscle protein called dystrophin that leads to rapid muscle deterioration and markedly reduced lifespan of about 35 years. Okay. Normally, we have dystrophin acts as a shock absorber. It lies between the muscle cell membrane called the sarcolemma and the contractile actin fibers inside of muscle cells. Now, without dystrophin and its shock absorbing effect, contractions, just simple contractions, will tear open the sarcolemma, which is, the muscle's uh, cell wall membrane, which just causes irreparable damage to the muscle fiber. Um, the muscle fibers will just die one by one and then are replaced with scar tissue and fat, causing a decline in motor function for the affected individual. From the same video I found on YouTube, they show 79 exons that are needed to complete the dystrophin protein. Uh, I like to think of it as, well, I like to use the analogy as jigsaw puzzle pieces. When some of the pieces are deleted, the remaining puzzle pieces may not be able to connect, and then any form of the molecule, the protein that we need in that cell will not be formed. Of course, 90% of the time, it's a deletion that will cause DMD because the remaining puzzle pieces cannot connect. This diagram illustrates how the X-linked chromosome of a carrier mother passes the recessive allele to her son. Women are the carriers of the defective gene and seldom show, again, any signs of the disease. The figure to the right provides a more detailed account of the DMD gene, particularly DP427BMP. It's a mutation at either of the hot spots at the top of the chart will cause an out-of-frame transcript producing dysfunctional and unstable dystrophin, if at all. And the graph at the very bottom shows which organs are specifically effective. They are the brain, muscle, and Purkinje cells, BMP, and they're highlighted in bright red. Here we are, hallmarks. DMD affects the entire body. It's a symptomatic disease. Symptoms of DMD become apparent at the age of 3, although there are testings that can be done on babies if they are suspected. Things like serum creatine kinase levels would be like 100 times normal, 100 times more than normal. Rapid muscle deterioration puts the affected boy in wheelchairs by their teenage years. They will breathe with the help of a ventilator by early adulthood. Most parents will die around 30 years old. Most patients will die around 30 years old from failure of the heart muscle due to contraction abnormalities of the left ventricle, behind the area behind the mitral valve, producing an algebraic sum of R and S waves in the ECG readings. Apart from muscular dystrophy and dilated cardiomyopathy, DMD patients suffer from deficiencies in the nervous system, smooth muscle pathology. For example, gastrointestinal tract blockages, and bone fractures. Below, we have the biopsy revealing the replacement of muscle with connective tissue and fat. The absence of dystrophin in muscle cells causes the mitochondria to become overloaded with calcium ions. An overall reduction of nitrous oxide starves the muscle cells of oxygen. Corticosteroids are used to counteract the inflammation response in patients. Deflazacort is a popular drug. Use of the drugs, however, will not cure the disease, only slow its progress. Here we have an example, a BBC article from this year. This young boy, 12-year-old Alfie, and his family cannot afford this new drug called Givinostat. It's an Irish boy. The drug that could, again, slow his symptoms. Gene therapy is a potential cure. However, they are only available to fractions of those with DMD of the full population and will produce dystrophin of limited function. Administration by virus can trigger the immune system, preventing further doses to be administered. Another important step towards proper diagnosis of this disease is to look for abnormally low serum creatine kinase levels, which I mentioned earlier. Even at birth and before the disease is clinically evident, SCK levels in boys can be as much as 100 times higher than in normal baby boys. Normal SCK levels are achieved at late stages of DMD. The reason being the escape of creatine kinase through the damaged sarcolemma. The decrease in SCK is due to decrease in functioning muscle as well as reduced physical activity. Here we have a really shocking photo. Duchenne muscular dystrophy causes pseudo-hypertrophy of the muscles instead. So it's really freaky to think that something that looks so strong is actually a sign of weakness, and the patient's muscles are actually dying. Here we see a child using the Gowers maneuver while rising from the floor. Gowers was another early pioneer helping to diagnose the disease. He was a very keen observer, and you notice that you can see the young man as his arms crossed. He's asked to keep not use his arms initially to get up off the floor. And this is their technique of getting up off the floor. And this is a 5-year-old child. You would not expect him to have to almost baby-like get up, straighten his legs out, and then use his arms on his knees, and finally stand erect with his feet spread wider than his shoulders. Again, here we are, a young boy walking on the tips of his toes. That's an early sign that his calf muscles are not developing. In fact, they're getting weaker as he grows older. Here's another example. This is named after another pioneer called Miriam. So this is a Miriam sign. The patient slips through the examiner's grasp when you're trying to lift them from under the arm. He was the first doctor to recognize this illness as DMD as a distinct illness back in the 1800s. Muscle samples are taken from the quadricep calf or the quadricep, which is the thigh muscle, or the gastrocnemius of the calf. So you look, what clinicians are looking for are fiber size, fiber necrosis, or dying dead cells, with evidence of phagocytosis, and replacement of muscle by fat and connective tissue. Here we have 3 photos to the right that allow us to compare. We have healthy muscle at the very top, followed by early stage DMD. And then you can definitely see the change from the top to the very bottom, where there's hardly any muscle left. And here, this is a great little newsletter I found from BMC Pediatrics, explaining the many techniques they're using to keep boys engaged and strong enough so they can perform their daily activities. They've devised special equipment, some using virtual reality technology to keep the boys motivated while they train their arms and legs. And here we have Guillaume Duchenne de Boulogne. He's the French neurologist, and he is he's the man who's got the name, the disease bears his name. He is credited with being the first clinician to practice muscle biopsy. He developed the tool to actually go inside the muscle and take a sample out. And that is the conclusion. I realize it's very short. There's a lot of very interesting things about this disease. And thank you. Have a nice day.